I want to introduce today a topic which sometimes in the mind of our surgeons, not only surgeons who perform endoscopic surgery, but in mind of all surgeons who perform also open spine surgery. This topic sometimes we consider as a very high fears, and we afraid to speak about this topic, and very often this topic which we will speak today we can consider as a nightmare of many surgeons. What is the name of this topic? This is the revision surgery, but not just revision surgery in any kind of spine surgery. But in this case, we will talk about revision surgery in case of endoscopic surgery, and particularly in UBE surgery. As we can see in this picture, revision surgery we have considered as a last step of evolution of any spine endoscopic surgeons, because we don't like to perform revision surgery. We sometimes afraid of it, but we have no way. We have to do it. We have to made it, because who can make it instead of us? We must do revision surgery, but sometimes we have a very difficult decision how we can to perform it, open or endoscopic. That's why I want to destroy all your fears today, and I want to explain you what endoscopic revision surgery is not a difficult procedure. But you also have to know what in case of about 90% of all revision surgery need to perform also instrumentation. That's why these three guys must help you in your trying. The type of revision problem. We can separate it on the next position. This is early recurrent herniation, late recurrent herniation, incomplete decompression, growing instability, adjust segment syndrome, after surgery complication like dural tears, epidural hematoma, and infection, and how we can to perform it in case of revision. I want to show you, it's only my own opinion. It's only my opinion, but you have to consider it not as a common suggestion, but only like my own opinion and only like my own suggestion. I very like this book which wrote very famous writer Stephen King. The name of his book is The Dark Side. But I have to introduce you another book which wrote by author of Medlon, and this is also has same name, Dark Side. But Dark Side of not only of particular person, but like dark side of any endoscopic surgeons. We have to forget completely about only possibility to perform open surgery in case of revision problem. You have to choose the way which you want to perform. The first way is very sad way, but second way, in my opinion, is very funny way. You have to forget about the open surgery, because UBE revision surgery is very easy. You have just to try it. I want to introduce the very common way to solve this problem. How we can perform this problem in case of any particular complications. We have to start from early recurrent herniation. How to solve this issue? The first of all, you have to forget about open surgery. Use previous skin incision and approaches. Good wound washing to have a clear view and removing a problem. It's not a problem, believe me, because in case of early herniation, when early herniation appear in 1 month after your first surgery, you can find any scars inside the wound, and that's why perform revision surgery in case of early herniation is very easy way. But in case of late recurrent herniation, we have to solve this issue in some other ways. But first of all, you have also to forget about open surgery. You have already think about your leaf, or you have already to think about instrumentation. Use previous skin incision and approaches. Good preparation of bone bottom. Try to remove a small part of lateral bone near the previous epidural scars. Never go directly through the epidural scars to avoid the dura damaging. Never try to free the margin of dura from scars. Go to disc laterally. Remove the herniation by inside out technique, not go directly to the disc. You have to completely recognize the margin of your scars and go more laterally from the scars inside the disc. Incomplete decompression. How to solve this issue? Use previous skin incision and approaches on the left. Good preparation of bone bottom. Never go directly through the epidural scars to avoid the dura damaging. This is the same steps. Never try to free the margin of dura from scars. Remove the needful bone tissue by drill using. Try to remove ligamentum flavum only below the new bone resection. Use enough of bone wax. In case of foraminal stenosis, you have to choose some another way. Use previous skin incision and approaches in case of right foraminal stenosis, and go sublaminar to the contralateral foramen. Use the paraspinal approaches in case of left foraminal stenosis, and go directly to ipsilateral foramen. In case of growing instability, you have already all time thinks about your leaf, because it is a strong indication for your leaf or to the instrumentation. The technique looks like a procedure in case of later recurrent herniation until the cage insertion. Good in plate preparation, bone grafting, cage insertion, and in addition for miscrews per level. We considered this technique a few presentations before. Very often we have a complication like just segment syndrome. We forget about the level which is located below our instrumentation level, because we always think about only level which located above our instrumentation. What's the reason? How to solve this problem? We have two ways. In case of instability, you have to prolongate your system to the level below or above. But very often we didn't have instability on the adjust segment syndrome. That's why it's completely enough to perform only a endoscopic decompression on level which located above or below. After surgery complication. They appear in acute period. That's why we don't know how to solve this problem. But in my opinion, you all the time have to completely know what you have to forget about open surgery. Use previous skin incision and approaches, good wound washing to have a clear view and remove the problem. What have we do in case of dura tears? I want to be honest with you because if you have a lot of surgery, you have sometimes a complication like dura tears. That's why how can you decide this problem completely depend on the size of defect. In case of dura defect less than 5 millimeters, you have just put the piece of Tokosil outside defect, and you have to hold the bed rest about 24 hours, and it's enough. What can you do in case of dura defect more than 5 millimeter but less than 10 millimeters? In this case, you have to use Tokosil inside the dura damaging, and in addition, you have to use the piece of Tokosil outside the defect. Bed rest at 48 hours. It also enough. The most problem when you have a defect more than 10 millimeters. You have to suture the defect. For endoscopic surgery today, it lead to some problem because it's very hard if you don't have good experience in this field. It's very hard to use suture inside the wound, but by using just one hand. That's why sometimes it's better to use Tokosil also, but if impossible to stop the dura tears, you unfortunately have to open your surgery wound and to suture the defect of dura by open surgery. I want to show you the I try to record all my videos from surgery room. That's why I have a very big storage of all my patient, and that's why it's very easy to find any complication or any very interesting situation in surgery room. I want to introduce you this complication. This is a third surgery. The first surgery was about 4 years ago. It was a open surgery. I will show you in cases and at the end of our presentation the full information about this patient. But now I want to show you how to manage the dura tears during your surgery by using just an endoscopic instrument. This is the approach of the level L3, L4, but transforaminal, and we go up to the level L2, L3. I will explain you at the next cases why can I choose this way. You can see the nerve root in the scars. You can see the margin of the dura. This is our revision window. And you can see the defect of dura. I will show you. The defect of dura is located on the angle between the nerve root and dura. I want to show you the most good picture, but if you can see Okay. Okay. You can see, yes, the defect of dura. And how can we manage it? We have just to put the piece of Tahosil to wait. It's very interesting pictures because some surgeons said that using Tahosil inside water space is impossible because Tahosil doesn't glue to the dura defect. But as you see, Tahosil very okay. This is the dura defect, and this is the piece of Tahosil, and it works in water space, in water surround. It's not very easy, but if you have some kind of experience, and you can see finally the piece of Tahosil very close glues to the dura defect, and only 24 hours bed rest after the surgery is completely enough to avoid the open leakage after surgery period. And of course, the very narrow way, but very narrow way to this to this place is also avoid dura leak in the at the postoperative time. Epidural hematoma. It's not a very good situation for us, but sometimes it's appear, and in my opinion, in my in some my patients, we have MRI imaging after surgery in 2 or 3 days after UBE, and very not very often, but sometimes we find the epidural hematoma without any neurological symptoms. In this case, you have do nothing, but in case of connection the epidural hematoma with neurological symptomatic, you have to decide this problem. How can you do it? In case of no deficit, do nothing. In case of deficit, hematoma on the level of surgery, endoscopic washing, hemostasis, use the VOX. In case then hematoma goes to another level, unfortunately, you have to perform the open revision. In case of infection, very similar way to decide this problem, like in case of hematoma. I want to show you common fears of surgeons before revision surgery. Scar tissue inside the wound may complicate anatomical orientation. Irrigation, water flow might be worse than during the primary surgery. Epidural scars may significantly increase the risk of neural structure damage. The duration of surgery will be incredibly long. It is simply impossible because I am afraid. I think what the last position is the most important for all surgeons because they just afraid because they think that it's impossible. I want to destroy your fears. I want to explain you what revision endoscopic surgery, it's not a difficult way to solve this problem. My main aim to destroy all these fears, because our fears are just a product of our mind, and our mind completely depends on our skills, experience, and our wishes to become better and more proficient. The first myth: the tissue scars inside the wound could make the problem with anatomical recognizing. The tissue scars don't make the problem with recognizing. How can we manage it? In case of carefully preparative design, what I mean, you can see on this picture the 3D reconstruction of patient before surgery, the picture during the surgery, and the endoscopic video during the surgery. As you can see, the 3D reconstruction and real image from the endoscopic camera, very similar. You can see on this picture and this picture, what they are very, very similar. And you can see at the endoscopic view also, what in case of good recognizing all structure, is very easy to recognize them during the surgery, because you have to completely have imagination about the 3D picture before surgery, and you will find this picture during the surgery. The second myth: water flow could be worse. In the fact, the water flow during revision surgery is always better. I think that it depends on the scars, because in case of revision surgery, some scars avoid the problem with water flow. The most problematic myth, for my opinion, epidural scars significantly increase the risk of neural structure injury during surgery. I think what, if you want to be honest, I think what scars sometimes increase the risk of neural injuries, but to avoid damaging the dura of nerve root, do not manipulate the scars. Instead, remove the structure, adjust to the scar. Don't touch the scar. To avoid damaging the dural nerve root, do not manipulate the scar itself. Instead, remove the structure, adjust to the scars. I will show you now on the real picture. Now you can see the very beginning of revision endoscopic surgery. You have to use, as I say you before, drill on the fresh bone, not go to the scars. You have to free the space under the fresh bone to completely understand the position of margin of your fresh scar, fresh bone. And now don't try to remove the scars, but instead of, you have to remove the bone near the scars. Then you reach the disc space. As you can see, I stop now this picture. As you can see at this picture, this is the disc. This is the margin of dura inside the scars. That's why never try to go through the scars. You have to go near the scars. You have to remove the scars and to see the margin, the medial margin of dura. You have to very polite remove the scars. And now you have a good space to go inside the disc by some kinds of remover or reamers. But you every time have to see the margin of dura in scars. In this case, you avoid any damaging of any neurological structure. After good preparation at disc space, as you can see, you go to the disc space near scars. You don't need to go to the scars, and you don't need to remove the, as you can see now, you insert the cage inside the disc space, also near the scars. But you have any time, all the time, exactly see the position of your cage and the margin of dura. In this case, it's very difficult to damage neural structures. As you can see now, the cage inside the disc space, and you can see the margin of dura, and no any damaging here. And the last myth, the time of surgery will be incredibly long. Fact, the time of surgery is quite shorter. It's very interesting, but I will show you at my end of presentation the real time of revision surgery. The equal time. And in my opinion, the most important our myth is just impossible because I'm scared. In the fact, revision surgery is not difficult. Don't be afraid of it. Of course, if you will go alone, if you go to the jungle and you will want to find the decision of this problem, the difficulties appear suddenly. But if you go with your friend, which have a good experience in this field, if he explain all features of this procedure, I think it will not be very difficult for you. I want to show you some cases. This case, male, 58 years old, a little bit overweight, 130 kilograms. You can see this is his MRI image about 4 years ago, before first surgery. First surgery was performed in some private clinic in Ukraine, but it was open surgery. It was a simple microdiscectomy, but I'm honored about the surgeons who performed this surgery because they were very honest, and they say all true about this problematic surgery. They didn't remove this herniation, and they had incredible complication like a dura tears. You have seen it in my before video. Then I show you the dura tears during my surgery. It was imaging before surgery, November 2023. It is the result of the surgery. If you can see, we have an interlaminar approach, and we didn't see the removing of the herniation. But as I said you, surgeons who performed it was honest, and they said to patient about all the problems. That's why we know about leakage, and we know about unsuccessful surgery. In June 2024, this patient went to our clinic, and he asked about help him. I don't like to perform surgery after somebody else, but in this case we decided to try to help him, and of course as you know, we have to try help him by endoscopic surgery without open surgery. And that's why we have a very hard decision. What way we have to choose for our approach. As you can see at this 3D reconstruction, this is the postoperative approach after first surgery on the level L2, L3. But we decided to not go to this approach because we honest afraid about, we know about leakage, and we afraid about leakage during our endoscopic surgery. That's why we choose the approach from transforaminal L3, L4, and we try to go up to the level of herniation. This is our approach after transforaminal surgery. As you can see, we went from the L3, L4 level. We save the all structure of spine. That's why we avoid the instability on this level. And our surgery was success, but as you see, we found the dural tears during this surgery, and they stopped dural tears by using the Tahosil. This is after our surgery. We removed the herniation, but this is picture after 1 year after our surgery. It was October 2024, and we have a severe instability on level L2, L3. That's why we decided to complete our surgery and to perform the ULIF surgery. As you can see, we perform ULIF on this level. We put the cage, and we also put 4 screws. All this surgery we perform by the UBE, by the endoscopic. The next case. It's a very interesting case. October 2023, male, 37 years, first surgery. I point was somewhere in galaxy far away from solar system. As you can see, monocage was inserted on the level L3, L4, but real problem was on level L4, L5. We don't know what was the reason of this surgery, but patient was in our clinic, and we have to make a decision how to treat him. That's why we decided to perform also endoscopic revision surgery. What we are going to plan? We wanted to go on the level L4, L5 to remove the herniation of central stenosis. Then we decided to put the cage inside the L4, L5 because of instability. And we decided also to remove the cage on the L4, L3 more deeper to the L3, L4, L3 level. As you can see, this is the CT scan before surgery, and cage was migrated to foraminal space. This is our surgery. This is a CT scan after our surgery. As you can see, we remove herniation from the L4, L5. We put the cage inside the disc space L4, L5, and also we remove the cage on the L2, L3 level more deeper. As you can see, this is our cage on the L2, L3, L4, L4, L5. And we remove a little bit cage on the level L3, L4. It is before surgery, it is after surgery. And this is the angle of lumbar lordosis before surgery. It was 27 degree, but after surgery, we increase the lumbar lordosis level angle to almost 51 degree. The next case is the spine surgery. We sometimes find very interesting cases. I try to all time record them, and as you can see, this surgery was at November 2018. First surgery somewhere in another galaxy. There's some kind of cage was inserted on the level of cervical stenosis, and as you can see, and we have predicted no improvement after this surgery. Lady has incredible high level of myelopathy. She has tetra paresis, deep tetra paresis, but then she came to a surgeon who performed this surgery. He said what he know the man who have to treat her, and he gave this lady number of our clinic. Then she came to us. This is the CT and MRI sky before surgery. We very long time tried to decide how to solve this problem. We decided exactly what we don't want to go directly to the anterior approach and to remove this cage, because I'm really afraid about the condition of esophagus, of trachea. That's why I decided to go on the posterior approach and to perform the just decompression. This is the 3D reconstruction before surgery and after surgery. This is MRI image before surgery, and this is after surgery. This is before surgery, this is after surgery. I want to be honest with you, as we predict any improvement don't happen. That's why I think what only one reason, this is the term after first surgery. It was about 6 years, and that's why it's impossible to predict any improvement. But lady says what the numbness and the weakness in her extremities a little bit decrease. That's why she was particularly satisfied after this surgery. The next case, this is my last case. I performed it last week. From 2015 to 2025, this lady has 4 surgeries on L5-S1 level from the right. It was just simple microdiscectomy and simple revision microdiscectomy on same level, on the level of L5-S1, as you can see on the right. This is her CT scan. As you can see, no disc space on L5-S1 level. And this is incision before our surgery. I want to show you almost all surgery. This is surgery from very beginning to the final. As you can see, what the very specific problem in this situation. This is the right side herniation and right side ULIF. In this case, we try to perform our surgery from the right side. Very often, I perform surgery in case of right side pathology from the left. But only in case of revision surgery and in case of paramedial herniation, I try to perform the surgery from the right side. It's very difficult for very beginners, but if you know all features of this procedure, it's not very difficult. But you have to completely understand the difference between the left side approach and right side approach. Maybe in few months I will prepare the presentation about. I have abstracts about full true in case of right surgery. My surgery team don't like the right side surgery, but now we have a very good experience in this field. What are the features? You have to all time use to have the good approaches. You have to use a needle. In case of L5-S1 revision surgery, in case of L5-S1 ULIF, you have to all time use, in my opinion, it avoid the unsuccessful approaches, because the approach in type of L5-S1 surgery, of course, in case of revision surgery, in case of ULIF, it's very important, because we have exactly trajectory for our future wound. Now I exactly know about the position of needle, because in case of L5-S1, it's very difficult to perform the AP through view, because the angulation of C-arm sometimes impossible to bend to achieve the good AP through view. That's why it's very easy to have a mistake in case of highlighting approaches. This is very important step. But if you waiting for some problem in case of, as I said to you before, bad water flow, it's not true, because water flow very good in case of revision surgery. It depends on the a lot of scars inside the wound. That's why water go out very, very good. Some difficulties appear in position of surgery team, because assistant in this case we have to consider assistant as some kind of help, some kind of a man who just take the devices from the nurse and put this device to surgeons. And very often, if nurse, surgical nurse, stay from the left side, sometimes she interfere me to hold the endoscope in my left hand. That's why I think what the right side surgery is completely full topic for the next presentation. As you can see, all time we try to use the 3D reconstruction to have a good imagination about position of all important bone structure inside our wound. As you can see, I all time try to see all these features, and to my imagination replace to the wound. In case of revision surgery, I suggest you to use not only the probe radio frequency 90 degree, but you have to all the time have possibility to use straight probe and to use a hook probe, because you have to remove the scars, and removing the scars is very easy by using the hook probe. As you can see, using the chisel is mandatory important, because you have to have a lot of grafting for the next cage insertion. And as you can see, this is another kind of probe. This is the straight probe. Now we reach the disc space, and we are removing the rest of disc space existing. Now, of course, we use bone harvesting for our grafting. We have to all the times check the position of our graft, because sometimes graft want to move to the anterior position of disc space. And now cage insertion. As you can see, you have to simultaneously have a two-level control. From the one side, you have to control the cage position of the endoscopic screen, but from the another side, you have to always time check position on the C-arm. And very important step is rotation of cage. We try to every time rotate the cage to from the oblique position to transverse position. We didn't have a specific instrument. We use any instrument which you have to use. It just maybe some kind of stick or some kind of chisel. Okay, and the last step is the mini-invasive screws. The time of this surgery is about 2 or 2.5 hours. Include the miss. And this is the direct recording of this surgery from very beginning. As I said before, I have all recording of all patients. I want to repeat once again what using the straight probe is very important in revision surgery, because you have a very polite and very exact use the only tip of this probe. First step, you have to free all bone and to compare your picture inside the bone with picture on a monitor, on a screen with 3D reconstruction. Because you're not the first here. That's why very difficult to not lose in this jungle. That's why, in my opinion, it's mandatory important step to at the very beginning of surgery, because you don't know what do you free now. You don't know exactly what the structure you now see. That's why after make you free the structure, you have to every time compare this picture, this particular picture with screen image. Using chisel is very important, and in my opinion, using the osteotome is very polite, because sometimes if you have seen at the first time, you have incorrect imagination, what impression, what using the osteotome is very rude technique. It's not a true. It's very polite technique. It's very gentle technique. But in my opinion, you have to use osteotome or chisel only in case then you completely sure about the position of facet joint. In this case, all your hammering will be success, because as you can see, all these pieces removing very easy, because I know exactly about the position of facet joint. Neither use the osteotome in UBE surgery if you don't predict and don't suspect the deep of the bone. Very often you just want to use osteotome in case of very deep bone. In this case, it's impossible to predict the line of your osteotomy. And now you can see some scars, yes? some scars, but then you see exactly the margin of bone. You have to predict that this scars is not very close to dura. That's why you have to remove it very politely, without possibility to and without any risk to damage the neural structures. I usually, in case of revision surgery, I try to go more laterally. I go more laterally, as you can see. I go laterally and exactly just below the bone, you didn't find any scars, and that's why if you remove this part of bone, it's impossible to damage any neurological structure because they don't exist here. If you remove some part of bone, you have to completely sure what it's impossible to, as you can see now. I go laterally, I push my caries and rongers inside the, I think, foramen, and that's why it's impossible to damage any structures. As you can see, hook. Hook is very important as a radiofrequency probe is very important to detach all structure which you not sure about the what do you do, but piece by piece, step by step, a little piece of scars, you remove this probe, this hook probes, and step by step you make the nerve root or make dura free. Okay, now you can see it's the right side. You can see the nerve root inside the incredible scars, but you didn't. You don't need to remove all these scars. Now you can see the pedicle of S1 vertebra, and you can see a disc space. You have to check this space. And the next step, you have to remove all rest of disc. Using a specific instrument for removing all rest of disc space. And the last step, as you can see, the end plates of L5 and S1 vertebral is very clear, and this is the open our way to make the grafting and the cage insertion. I don't stop recording the movie. This is the last step of our procedure. the vision in during the cage insertion sometimes worse because you close the way for all water flow. In the final step. As you can see, the full time of surgery from very beginning to cage insertion, 1 hour and a half. That's why I think what it's not a bad term. And this is our picture after surgery. As you can see, bone graft made like some kind of pillow close to cage, above the cage. This is the cage, and this is the bone graft near the cage. And the 6th incision near the old scars. I want to compare our presentation with very famous myth busters, and I want to introduce my conclusions. The tissue scars don't make the problem with recognizing. The water flow during revision surgery is always all better. To avoid damaging the dura of nerve root, do not manipulate the scar itself. Instead, remove the structure, adjust to the scars. The time of surgery is quite shorter. Revision surgery is not difficult. Don't be afraid of it. I want to thank you. I want to, every time at the final of my presentation, I every time introduce my team because we only successful when we work together. And this is the my final suggestion. And remember, this is my team in vision of artificial intelligence like a Simpsons. And remember, UBE is not a microdiscotomy through a 2 incision. UBE is completely independent surgery. It's my clinic Midlon by vision of also artificial intelligence. And our clinic is very small, but as I say you, we every time ready to help you improve your knowledge, to improve your skill, and to help you in any question which you want. Thank you so much, and I want to answer all questions you ask me.
Yeah.
Thank you so much, my friends.
Thank you. Can you please stop your screen sharing? Yeah. Thank you, Dr. Yuri, for your valuable insights today. On behalf of all participants, thank you for your time. As a moderator, I want to ask one question. Because there is any bone, no spinal laminar junction. Where are you landing exactly?
In case of revision surgery, you have to completely understand what your working endoscopic port must be exactly on the level of your pedicle to have a possibility to insert the screws. But what about target point is very interesting question because, as you know, in case of recurrence stenosis, we don't have a possibility to find a spinolaminar junction. In this case, I suggest you to use very close bone, which not far from your target point. I mean, it doesn't matter to go to your target point as you go to stenosis, because 95% of revision surgery completely depend not with central stenosis, but with recurrence of herniation. That's why, in my opinion, in my practice, I use for target point not spinolaminar junction, but I just use the facet joint. The facet joint between SAP and IAP.
Yeah, thank you.
Welcome.
Dr. Ayhan Kanat, thank you for this good presentation. You said your surgery time is 2.5 hours. You mean surgery time is short? It looks longer than microsurgical dissectomy, he says. But I think it includes uh, in MIS screwing and uh, cage insertion.
The middle time of revision surgery or relief sometimes depends on the constitution of patient. Sometimes it depends on the level of scars inside wound. But in my experience, the middle time of revision surgery expect of mini invasive screws from 1 hour to 2 hours, not more. From 1 hour to 2 hours. It includes the approach, it includes the disc revision, it includes the decompression of neural structure, it includes the disc space preparation, it includes bone grafting, it includes the the cage insertion. The mini invasive screws also depend on the level. In case of L4, L5, or L3, L4, it takes not more than 25 or 30 minutes. In case of L5, S1, it's more complicated. That's why in case of L5, S1, it takes usually about 30, 35 or 45 minutes. In case of 4 screws. In case of 6 screws, it takes about less than 1 hour. That's why the completely terms of our surgery from 2 hours to 3 hours.
Yeah, thank you. As far as I see, there is no comment or question. I want to ask Dr. Çiğdem Mumcu here with us, and she's the imported member of UBE Society in Turkey. Maybe she want to say something.
Yes.
Kamil abi.
I was sent the request. Çiğdem Mumcu is a well-known UBE surgeon from Turkey, but I'm not sure if she's
Available or not.
available.
Yeah.
I think she's not here. Maybe one more time. Okay. So I think she's not available right now.
Maybe you. And one more question. And what is your recurrence rate? Dr. Ayhan Kanat asks.
Recurrence rate.
Can you compare conventional microsurgery?
Maybe Professor Kanat didn't aware these are the revision surgery, not first time microdiscectomies or first time UBE surgeries. These are already recurrent cases.
My recurrence rate in case of UBE surgery.
He is asking this, but these are already recurring cases. And maybe you can mention about your first time UBE surgeries.
My recurrence rate in case of microdisc.
Simple discectomies.
Simple disc, about 7%.
About
7%, 5-7%.
Okay.
But I point what the recurrence rate in case of right herniation is higher in compare when left herniation. That's why I relate if with case then we perform the right side herniation from the left side in case of paramedial location. In case of simple lateral location, it's very good to perform the surgery from the left side. But in the case of paramedial location, sometimes we reach a not completely removing the herniation. That's why now I try to perform the right side surgery in case of paramedial location from the right side, because in this case I try a possibility to make a good revision of paramedial location of hernia. That's why, in my opinion, right side herniation has a bigger rate in relative left side.
Thank you.
Yes, thank you.
Yuri, also, I want to ask that about this recurrent case of you went through the transforaminal, UBE transforaminal from the right side, I think.
UBE transforaminal from the right side, I performed only from the right side.
Okay.
Only from the right side.
In case of this case, you showed you went through transforaminal. What do you think about the classical transforaminal in this case from lateral side, monoportal transforaminal? It seems to me it's can be used traditional transforaminal monoportal approach
Yes, why not?
in this case.
For revision, of course, you can use it, but just for revision, just for decompression, just for removing the rest of hernia, but not in case of. I'm sorry. Somebody calls me.
Okay.
Very
I see
sorry.
we cannot perform any stabilization, or we cannot put. Maybe we can put cage, but we cannot. Okay, I didn't try actually. Okay. Thank you so much.
I'm sorry.
No,
Okay. Sorry.
you already answered this. So, Efecan, I think
Yeah.
we finished
Yeah, we finish.
all the.
Thank you for your great lesson, as always.
Okay. I hope see you in Ukraine or Turkey in a short time. I think we cannot go to Spain. Efecan, maybe you want to go?
Maybe.
Why
maybe.
not?
And Jakob from the Georgia says thank you and Happy New Year.
Thank you so much. Thank you so much, my friend, for incredible good conversation, for discussion. I'm glad to see my friend from Lviv city, Zaryan Saldan. Hello. Thank you so much for attend this meeting to share our knowledge and to try to be better. Thank you so
Okay.
much.
Dorian, is that you? So, I couldn't recognize you.
Zaryan,
So,
you can say something.
okay, you can turn on your microphone.
Something. Oh, yes. I'm very glad to see everyone. Do you see? Especially Dr. Hassan and Dr.
Yeah.
Yuri, and I very appreciate. I very appreciate the experience, Dr. Yuri, and if you don't mind, Dr. Yuri, I have one a little question for you. Please, is it not necessary to use instrumentation immediately during revision to prevent hernia recurrence in lumbar level? What do you think about that?
I think what you mandatory have to use instrumentation is in case of revision surgery, but in my opinion, the most thing you have to point is the wishes and opinion of your patient. If patient doesn't want, it not necessary to explain him. The final decision not for you, final decision for patient, because patient must to pay for the all instrumentation devices. That's why I try to all the time. Then I have a recurrent herniation. I every time try to explain to my patient the importance of instrumentation, but the final decision on him, complete only on him. That's
Thanks.
why yes,
Thank.
I sometimes use just revision without any. Of course, in case of early herniation, I think what about half of my revision surgery without instrumentation. But I try to explain this problem. That's why it completely depends on the wishes of patient. Thank you. Very, very
Thanks.
good question. It's a
Thanks.
question for Ukrainian people.
I couldn't recognize Dorian all the time. Sorry.
Okay.
Maybe I speak English better, but I learning now.
Okay. I want to call Dr. Mumcu one more last time, and if she is available. Also, maybe İsmail Safasatoğlu, my friend, orthopedic surgeon from İzmir, want to say something about. Okay, Safa.
Dr. Yuri, it was an excellent presentation. I thank you. Last week, I have also listened your lecture about the cervical spine. And this for the revision surgeries, it will encourage us to perform the revision surgeries with UBE after your presentation. Thank you. I thank you a lot.
Thank you so much. I appreciate your opinion. Thank you so much. It's a big honor.
It was an excellent presentation. Thank you.
Thank you.
It was really indeed. Thank you so much. I want to thank everyone who joined us today, and hope to see you again, my friends. Zorian, Yuri,
Yeah.
and
Thank you so much. I maybe
okay.
see in Syria.
The Georgian friends from Giga, you was there, but you disappeared. Giga was here just for a second and
I can't
disappeared.
see him.
He suddenly disappeared.
Yeah.
Yes. Okay. Hope to see you.
Thank you. Hope
Thank
to
you
see
so
you.
much.
Thank you,
Bye-bye.
my friend. Bye.
Bye.